This is very well known to everybody. The advantages of sonography for guiding procedures and the difficulty for ultrasound to assess the result. You know very well. It's impossible. If you don't use contrast, you cannot do anything with sonography. Second concept, with any kind of therapeutic modality, there is a margin of unpredictability of the results. So monitoring the treatment is really always very important. You can use, for example, the volume of the gas formation area to approximately assess the result of treatment. In reality, this is not particularly useful because usually this overestimates the real amount of necrosis. If you are lucky and you can use MRI to guide your treatment, so under MRI, you can use the so-called isotherm curves, which show you the distribution of temperature around the target, which is important to assess the amount of necrosis. If you cannot perform the treatment under MRI, which is always a reality, for example, in Italy, I don't know in other countries, and you have to use ultrasound, the best modality to assess immediately the result is enhanced sonography. And I will show you some examples. This is a historical example. This was 1999, 10 years ago, when we decided to check what was possible with enhanced sonography at the very beginning of the experience in the world. And this was the first case, hepatocellular carcinoma. We injected the contrast agent at the end. This was the result. And when the next day, the following day, we performed CT, and we saw this extraordinary similarity of the two images, we understood that probably the potentiality of this method was really important. So, as I told you, we usually wait for a few minutes after the end of the treatment, and we inject Sonoview to assess the result. Usually, we suggest for every lesion to also perform an injection of Sonoview just before starting the ablation in order to compare the pre and the post-treatment immediately. When years ago, many years ago, we made the first comparative test without the use of enhanced sonography and with the use of CEUS, we saw that there was a very important advantage in terms of reduction of partial responses and also the cost-effectiveness of the method, because using enhanced sonography, you save many cases of incomplete treatments, which are, for many reasons, expensive in terms of money, but also important for the patient, because the second treatment is not usually well accepted by the patient, days or weeks after the previous one. And we saw that the cost of the contrast agent employed was equivalent to the cost of a very small number of lesions compared to the number of lesions which we saved, having understood immediately that the treatment was not complete, and we completed the treatment in the same session. What I'm now telling you now is written. Till a few years ago, this was not written. Now you know that there are the European guidelines for the use of CEUS, and monitoring of local ablative treatment is included as one of the main chapters. Facilitation of needle positioning, evaluation of immediate treatment effect, assessment of tumor recurrence, and so on. So this is now stated and well demonstrated. CEUS is not particularly useful in the first phase, in the interventional planning. It means before enrolling the patient, because ultrasound is not a panoramic modality. And especially for cirrhotic patients with HCC, it's impossible to replace CT or MRI before enrolling the patient to assess the real number of lesions present and the location of all the lesions. Cases like this can only be assessed, for example, with multi-detector CT, not with CEUS. Sometimes CEUS before the treatment can help you in some very particular cases, for example, in some cases of metastasis, showing, sometimes even better than with CT, the hypervascular halo which surrounds the necrotic part of the tumor, of the metastasis. This is important to give you the real size of the real neoplastic lesion. This is not neoplastic, this is necrotic. The real neoplastic area is the halo around. So this helps you to plan how many insertions you should perform and where. As for the real-time guidance, there are some particular cases in which sonography can be useful, enhanced sonography. For example, in this case of recurrence close to a previous necrotic area, you see that the enhanced sonography shows you very clearly the new tumor and the necrotic area, much better than unenhanced sonography. And you can target immediately the enhancing area in real time. In this other case, for example, new lesion inside a necrotic area of a previous treatment, but where it is for sonography, we don't know. And if you inject SonoView, it is extremely clear now, you see in a moment, where is the new neoplastic area, and you can, in real time, target exactly the enhancing area, avoiding the already necrotic portion all around. And this is the result the day after, with the precise treatment of the new neoplastic lesion. What about treatment monitoring? What is the timing for contrast administration after ablation? Here I always write RFA, it's a sort of habit, radio frequency. Now I should tell you that in most cases we are replacing radio frequency with microwaves, both for HCCs and for metastasis. For many reasons, microwaves are better than RFA. But in these slides, you always see RFA. It means ablation, generally speaking. 5-8 minutes after the withdrawal of the electrode is the best timing, because if you inject contrast at this stage, when you have this impressive amount of gas, you see nothing. So it's really useless. But if you wait too long, too many minutes after the withdrawal of the electrode, you may have this situation of the very fast formation of the hyperemia around the focus of necrosis. And sometimes it's not so easy to differentiate reactive hyperemia from still viable portions of the tumor. Of course, hypervascular lesions, hepatocellular carcinomas. This is not a problem for metastasis, for example. But so we have the sort of very strict window, time window, when to inject agent after ablation. The suggestion, as I told you, is always to compare the image just before treatment and the image after treatment in order to see the difference of size and also to compare the location of the lesion. This is necrotic area, this is hyperemia all around. While, in this case, this is not hyperemia. These are areas of untreated part of the tumor. So you need to immediately retarget this area and finish your treatment. What is the optimal time to measure the size of the avascular areas at the end of ablation? Few minutes after that gas has disappeared. And the size is sometimes different. For example, at 2 minutes, this necrotic area seems to be 1.7 centimeters. If you wait 2 more minutes, it's 2.2 centimeters, because the effect is not immediate. You have to have a few minutes to assess the real size of the necrotic area. Just to mention, the potential risk of enhanced sonography in this post-ablation control may be the slight underestimation of the volume of necrosis. Never overestimation, always underestimation. But you understand that the underestimation is not a big problem. Overestimation would be really an important problem. How can I differentiate untreated areas from treated areas after the ablation? When you have bubbles which move inside the necrotic area, move inside the vessels, it means that you have still blood vessels, and this should not be. It means that the area is not completely treated. Let me show you, first of all, this case on your left side here. You see that there are bubbles moving inside just along vessels. This cannot be accepted. In my opinion, in our opinion, this is a lesion which must be immediately retreated in the same session. You see here vessels inside. On the other side, you see here a very wide necrotic area, and this gas here is not moving. This is gas produced by the treatment. So bubbles moving inside the necrotic area usually mean still viable portions. Bubble fixed, not moving, usually are created by the treatment. So these are not significant. The criteria to evaluate the response now are well stated in the European guidelines. I don't need to read all this piece of paper here, but it is summarized by what I'm telling you. Is there any significant correspondence between the assessment achieved with CEUS after the treatment, and the assessment achieved with CT or MRI the day after the treatment? Usually, yes, and I will show you some data of the literature right now. Usually we have a slight underestimation in terms of few millimeters, but as I told you, underestimation does not represent a significant clinical problem. Overestimation really would be a real problem. Let me show you this case of this metastasis here. The first ablation, the first insertion, gives this amount of necrosis. If you compare this volume with this volume, they are extremely similar. It's totally ineffective treatment. So you must immediately enlarge significantly this area up to this size at least to consider your treatment probably efficient, valid. What is the reliability of CEUS? These are the very first studies published in the literature, you see, many years ago, and usually they were studies performed with the first generation contrast agent, the old Leibovist. In spite of that, you see that the accuracy was quite good, more than 90% in all cases, sometimes more than 95%. More recently, several papers were published regarding the use of second-generation contrast agents, some of you in practice, in this kind of follow-up after ablation. And you see that studies are from different countries, different areas of the world, but the percentages are really excellent. 98, 100%, 95%, 96%, 91%. So all of them are more than 90%, which confirms completely what we found some years ago in the slide I showed you a few minutes ago. So the system is accurate, is acceptable in terms of immediate control of the result of ablation. The other advantages are that you can do all these assessments in the interventional room without moving the patient out of the sonographic room and go, for example, into the CT or the MRI room. The possibility of multiple administrations in order to check further insertions and further results in the same patient. There is also a demonstration of this study from the group of Barcelona demonstrating that you have an improved survival if the complete necrosis is achieved at the first ablation, so without the need of retreating the patient. And if you can achieve this result using CEUS, this is a good advantage for CEUS. Finally, how can you differentiate, according to the same author in Barcelona, the differentiation between hyperemia and residual tumor? Homogeneous enhancement suggests hyperemia, while the absence of washout in the portal or better late phase suggests hyperemia and not residual tumor. These are two elements which must be considered. Let me show you finally one more possibility, which is on your right side here, where I start now the movie, that you can also, for example, follow with the enhanced sonography the retreatment after partial chemoembolization. You can mark, for example, in red, as in this case, the still viable portions of the tumor after TAC, and then you can follow these areas, these volumes, with the fusion system I showed you before, and injecting at the end CEUS, some of you. So I'm very close to conclude. What do we do in our clinical practice every day? Usually when we have lesions easy, small, very simple to treat, we use the pre-treatment study with sonography, enhanced sonography, and CT or MRI, and ultrasound during the procedure. When we have difficult lesions, difficult means large or in critical anatomical location, poor or no ultrasound visibility, and so on, we use CEUS, we use 3D real-time ultrasound, and image fusion, as I showed you before. But what is important, we do not use enhanced sonography for the follow-up after treatment. CEUS cannot, in our opinion, replace CT or MRI for the follow-up of these patients. We usually employ CT. In some cases, we employ MRI. And we are increasingly employing diffusion-weighted MRI. Diffusion-weighted MRI has, in our opinion, a very high potentiality to show you in a very early phase the completeness or incompleteness of the treatment. This is a typical, just one example. MRI after treatment seems to be an excellent result, seems to be a well-demarcated area of necrosis. The same day, 24 hours after the treatment, we apply, in the same study, diffusion-weighted MRI. And this hyper-intense area here on diffusion-weighted MRI means incomplete treatment, means still neoplastic tissue. And in fact, we decided to wait and see. We did not rely on this image the day after the treatment. This image the day after the treatment. 1 month later, also conventional MRI showed exactly what diffusion-weighted showed us 1 month before. So my strong suggestion is for all of you, if you can have diffusion-weighted MRI available in your departments, to start using this modality. There are not yet many results published on that. It's a really new technology in this field. But in my opinion, it is extremely promising for the future. Thank you very much.